Good morning. Welcome to the Data Intensive Research Conference. Hope everyone had a nice lunch and enjoy this talk. So let's get started in our session of the family care work. So I'm Jiao. I'm a postdoctoral associate at Minnesota Population Center and IPUMS. So it's my pleasure to chair this session on family care work. And today we have 3 excellent papers in our session. So I'm very much, just like both of you, looking forward to hearing their talks. So with that, I will introduce our first presenter. So okay, we have Xinyan Cao presenting education and work-related time use. Xinyan is a second-year sociology PhD student at Brown University and a trainee at its Population and Training Center. Her research interests are education, health, demography, immigration, and inequality. So without further ado, let me turn it to Xinyan.
Hi, everyone. My name is Xinyan Cao, and I really appreciate people pronouncing my name very correctly. I really appreciate this chance to present this work here for the first time. So any comments are really welcome in the Q&A section. We know caregiving is very time consuming for the caregivers, and it may create time conflicts for their personal development activities. And in this study, we recognize that not only caring for aging population that is caregiving, but also childcare is very time consuming, such as helping kids with their daily activities of living and their education and caring for their health. Right now, the average age of caregivers is about 50 years old, but young adults are still over a quarter of the caregiver populations in the US. Not only young adults of recipients aged 18 and above, but also young adult parents. Young adults are often defined as 18 to 49 years old, but are they a homogeneous group of caregivers in terms of their time conflicts? So I often ask myself that, well, I have the same time conflicts. If I have a 3-year-old kid right now, and if I have a 3-year-old kid when I am 35 years old. So in this study, I divided the young adult groups into 2 groups. The first is the youngest young adults, age 22 to 30, who have just got out of education or they're still in education. And the younger middle-aged adults, aged 31 to 40, who may have been away from school for a while and started their career path. So my first research question is, how is caregiving related to their education time? So we all know young adults are more likely to be enrolled in school, and they have more time available for education than middle-aged adults. Once they become caregivers, they may have substantially less time for education than their non-caregiving peers, but this substantial decrease may not be as significant as it is among middle-aged adults. So my first hypothesis is caregiving associated with less time on education for all caregivers, but even less for young adult caregivers. My second research question is, how is caregiving related to their work time? So there are 2 situations. Young adults are more financially vulnerable than middle-aged adults, and they use less non-relative care. So it's less likely for them to purchase care services. But for middle-aged adults, the importance of family life stands out more because they are more likely, there's greater propensity for them to be married and have kids. So to be consistent with hypothesis 1, my hypothesis 2 is caregiving associated with less time on work for all caregivers, but even less for young adult caregivers. And my last hypothesis studies the gender differences. So women are more likely to be family caregivers, and they are more likely to do intensive family care. The negative effects of caregiving situated in the first two hypotheses may be larger among young women than they are among young men. I use American Time Use Survey from 2003 to 2020 to examine these hypotheses. I have a sample size of 67,499. They're all aged 22 to 40. And I have two outcome variables. The first is weighted everyday minutes for education, which is non-work education. And I have weighted everyday minutes for work, including job search. I have an age dummy variable. So 1 means young adults, age 22 to 30. 0 means middle-aged adults, 31 to 40. And I have 3 different caregiving variables, dummy variables: childcare, elder care, and a new variable named sandwich care, which means the respondent reports childcare and elder care at the same time. So they are the sandwich generation, just as the sandwich we had for lunch. They are sandwiched between childcare and the need for their elderly parents. And most likely they live in a multi-generational family. Most likely. I will look into that. And I have a gender dummy variable. I have 2 gender dummy variables, and I have control variables for caregivers, personal and their family characteristics. And with this data set and variable, I created 2 equations, very similar equations. In the first equation, the outcome is everyday minutes for education weighted. And I have a young adult dummy variable, have a caregiving dummy variable, 3 types of caregiving in 3 different equations, and I have their interactions. I also have occupation state fixed effects to account for the possible differences in the healthcare and family policies across different occupations and in different states, because the US doesn't have a universal childcare and healthcare policy. So equation 1 creates models 1, 2, 3 for 3 different types of caregiving. And each model is run for all respondents and also by gender. So when we see a negative beta S, that means caregiving is related to less education time for all caregivers. And if we see a negative beta K at the same time, that means it's even less education time for young adult caregivers, which is also a difference in different test coefficient that tests the difference in caregiver and non-caregiver time gap between young adult caregivers and middle-aged adult caregivers. If we see both negative beta S and beta K, that means it's consistent. The findings are consistent with hypothesis 1. 2 works in the same manner, in a similar manner, and creates models 4 to 6. So when we see a negative beta S and beta K here, that means the findings are consistent with hypothesis 2. Now let me highlight some important findings here. So looking at model 1, we see that childcare is associated with less time for all caregivers and even less for young adult caregivers. And this even less is mainly among young women. And so we see that model 1 is consistent with hypothesis 1. And when we look at model 4, sorry for the weird numbering here, we see that childcare is associated with less work time for all caregivers, but it's mainly observed among men. And this even less effect is again mainly among young women. So model 4 means the findings are consistent with hypothesis 2. And I did more coefficient tests to test the differences between gender, young women and young men, and there is no significant differences between them. So the findings are not consistent with hypothesis 3. And the situation with sandwich care is a little bit more complex. So sandwich care, as we see in model 2, sandwich care is associated with not with less time for all caregivers, but less time for young adult caregivers only, and it's mainly among young men. So model 2 is partially consistent with hypothesis 1. And in model 5, we see that sandwich care is again associated with less work time for all caregivers, and it's mainly among men again. And we didn't see the even less effect for young adults in terms of sandwich care. So model 5 means the results are consistent with hypothesis 2 and partially. And again, hypothesis 3 is not approved by the coefficient tests. Let me talk about more about the potential reasons behind these results. And also, I have no effects of elder care on both education time and work time. I can talk more about these no effects later in the Q&A section. Now, let me move on to the main conclusions. So first, the caregiver and non-caregiver gap in education time is larger among young adults than among middle-aged adults. And who are the biggest contributors of the caregiver and non-caregiver gap in education? So in terms of childcare, it's not young men, but young women with and without childcare who contribute most to the education gap. In terms of sandwich care, it's not young women, but young men with and without sandwich care responsibilities who contribute to the most of the gap. And second, the caregiver and non-caregiver gap in work time is also larger among young adults than among middle-aged adults. And who are the biggest contributors? It's again, not young men, but young women with and without childcare responsibilities. So what do they further imply? Young women with and without with children spend substantially less time for their personal development, their education and work than young women without children. So that means there are gendered expectations of childcare exclusively on young women, and young women are more vulnerable than middle-aged women. So there are gendered expectations of childcare on the more vulnerable population, young women population. And then lastly, sandwiched young men spend substantially less time on education than non-sandwiched young men. And that reflects that young men are increasingly involved in the housework and family care because there are rising demands of elder care right now. But young men would not sacrifice their work time. They sacrifice their education time and they sustain their work time to still be the family providers for the family, to cover the cost of the family. Some policy implications are there should be accessible and affordable healthcare and childcare alternatives for households where young adults are the primary caregivers. And for employers should increase young employees, actually all employees, schedule control and workplace flexibility. And sometimes, as highlighted in recent studies, there are negative career stigmas against flexible scheduling because people believe that working flexibly may lead to negative work outcomes. So people tend to not require flexibility. But we should address the negative career stigmas against flexible scheduling. Thank you, everyone. I'm happy to talk more about these topics in the Q&A section.
Okay, thanks, Xinyan, and for your amazing talk. So our next presenter is Yongxin Shang. Yongxin is a PhD student at the Brooks School of Public Policy at Cornell University. She is also a graduate student affiliate at the Pop Center. She received her bachelor's in economics and sociology from Peking University and her master's from Chinese Academy of Social Science. So she is interested in family demography, health inequality, population aging, and family caregiving. So, okay, Yongxin, the floor is yours.
Hi, everyone. I'm Yongxin from Cornell University. Thanks, Jiao, for your great introduction. And my presentation is actually into multi-generational caregiving in later life, age and gender patterns. So my presentation is related and also distinct from Xinyan's presentation just now. We are both focusing on caregiving, whereas she is focusing on younger adults and I'm focusing on older adults. And she is using caregiving as a predictor of the stratification in work and education time, whereas I was focusing on age and gender as how they're stratifying the caregiving patterns. So yeah, let's go to the. So here for my motivation for this research is pretty much motivated by a demographic trend that we are more likely to share lives with multiple generations of family members, mainly driven by increasing life expectancy. We are living longer and we are also living longer with our family members. And there is a growing literature on the demography of grandparenthood. And there's some recent demographic research showing that older adults with 3 generations of kin, as shown here, like they have their parents, their children, their grandchildren. This type of family structure is actually more common than those only with 2 generations of kin with parents and children in age 50s and 60s. And also, the length of healthy grandparenthood is also becoming longer, despite there is a delay into transition into parenthood and also grandparenthood. They are actually offset by this increasing life expectancy. So here it leads to a concept of potentially being sandwiched, like as this title shown, like whether this multi-generational family ties is an asset or like a burden. I'm mainly focusing on those like potential burden, like you are having those multiple generation ties and you are potentially facing the care demands from different generations. So that is my focus here. And there has been some challenges studying the multi-generational caregiving because definition really matters a lot. So first, there is a distinction between the potential to provide care, to face care demands from different generations. And among those potentially sandwiched, only some of them are actually providing care to different generations simultaneously. And here also leads to the second point here, like is care for whom, whether care for your children or parents simultaneously or caring for children and older adults in general, that is also another definition issue we need to consider. And what type of care, and there are many time transfers and also co-residence as a common way of those international transfers. And also there's recent research like including emotional care into this counting of care can increasing this share of caregivers in general. And apart from those simultaneously providing care to different generations or the so-called sandwich generations we have heard a lot in the presentation just now, there is also a possibility for you care for multiple generations at different care episodes or successively, like you first care for this generation at one time point of your life, and then you care for another generation afterwards. And there's actually been some statistics showing that although there is not much providing care simultaneously, there's like a larger share of women actually ever provided care to different generations at some time in life course. And here it goes to this gendered part. And yeah, it's no doubt that a lot of research has shown that women are consistently more likely to provide care than men throughout the life course. But interestingly, later life, there seems to be a reverse in the trends at very older ages. Seems like men are increasingly more likely to become caregivers, and this may probably driven by the demographic factors about this mortality selection. Like usually, like women live longer than men, and so like older men tend to more likely to have a disabled partner or spouse to care for them, whereas it's not the case for women. And there's also a social rhythm that a lot of research like showed that employment status like retirement actually made men more available to provide care, like less likely to be excused out of like not providing care like after their retirements. So yeah, this is a kind of interesting finding here, like in later life caregiving patterns. But taken together, like there's a gap in terms of the research on gender patterns on multi-generational caregiving. There's more research is only focusing on like gender differences on one type of caregiving, but not much of them like are considering only this all types of caregiving altogether and see how they play out differently across gender and across age. So yeah, my research is mainly like descriptive research and in some sense explorative. And I have two aims. The first aim is to map the overall patterns of multi-generational caregiving by age and gender among those 50 plus. And here as I mentioned in the front end, like I emphasize this distinction between potential to provide care and the actual care. I brought Albertini's recent research on this terminology, like demographically sandwiched, which is the potential to provide care, and socially sandwiched is actually providing care among those with potential. And I also like adopt a broader definition of care for whom, following this recent research, like not only for like caring for parents and grandchildren, also including those spousal care, an important part of care in later life. So here, like being sandwiched, I defend them broadly, child care plus elder care, including parent care or spousal care. And my second aim is pretty like still ongoing work is to explore the sequential patterns of multi-generational caregiving in later life, like see this from a life course, like when to care for one generation and then another generation, like to list this like sequentially to see whether there are some interesting patterns. So I use HRS data, 1998 to 1914. Starting from 1998, HRS became nationally representative of all older adults aged 50 and older. And this is a biannual survey with abundant information on this transfers to different generations, which is not always available in other similar surveys. And I exclude those non-response and observations with missingness in my analytical sample. So here is my first analytical sample to see this overall patterns, age and gender patterns, to provide a snapshot of these populations during this observation period. And analytical sample 2, I will explain more in later presentation. So here is how HRS measure caregiving. I adopt a relatively narrow definition of care. Is like providing personal care to different people. And here is parent care, like your parents or parents-in-law. The potential is like they're alive. So if they are still alive, you are still potentially maybe face care demands from them. And this is for the measure of actual care. Like this time frame is like reference period is in the whether you have cared for more than 100 hours in the past 2 years. And here is grandchild care. Also, here is the potential, the definition for potential, like you whether have any dependent grandchildren. But here is the limitation in HRS, like we do not know exactly the age of grandchildren. So here, yeah, it's definitely a limitation. I just as long as the respondent has any grandchildren, I will assume they have this potential for grandchild care. And here is a similar definitions for child care, grandchild care, similar to parent care. And spousal care is like kind of indirect way, like usually the partner spouse is also the respondents in HRS. So they will ask whether you receive help from other with ADLs or IADLs and whether your spouse is listed as one of the caregivers. So it's kind of an indirect matter of those spousal care. And sandwich care is similar to what I just talked about, like simultaneously, like child care and elder care. And here is the descriptive of these different types of care, like the proportion of care at different age since 50 to 90. And I show it separately for men and for women. And you can see that the blue line is for parent care is a lower line compared to other types of care. And this spousal care, the green line is actually increasing for both men and women, like in later life. And the peak of this, like most likely to providing spousal care is actually later, very later here for men than for women. And grandchild care is the most prevalent, like in those like earlier older adulthood, and the peak is around 65, like for both men and women. Although I do not put them together, but you can see that overall in the population, like women is more likely to have a larger share of providing care. So here, let's see like a snapshot of being sandwiched. And so here, so in this panel, like it's simply like parent or spouse care plus grandchild care. And this is like demographic sandwich, which means like you have potential to face competing care demands from them. And you can see that this red line is for women, and this blue line is for men. And you can see that men is like after like 55 is like higher than women's line. And here like, I distinguish between parent plus grandchild versus spouse plus grandchild. And you can see that especially for those dotted line for those spousal care and grandchildren is always increasing, and especially so for men at this like after age 80 like is much higher than women's, like largely due to those selective mortality as I mentioned in the front end. So yeah, and among those with potential of those demographically sandwiched, like what are their care arrangements? So I used this stacked bar graph to show that like at different age groups, like it's this white part is like they are potentially sandwiched, but they are not providing care to any generations. So it's a pretty large share, larger share among men. And here is the orange bar is for grandchild care only. And then for the parent care only, and for spousal care only, for those like green bars, like increasing very strikingly here, like at very older ages. Whereas for those like actually providing care to different generations simultaneously is pretty a small part, right? Like it's although like it seems like more prevalent like for those spousal care and grandchild care simultaneously, like after age 60. But overall, comparing men and women, like among those with potential is always like women more likely to actually providing care to different generations. So here is just a kind of a summary of those like among the full population, the share of actual sandwich caregivers and how gender the patterns like differs across age. And you can see that whether for like parent care plus grandchild care is like for those from 50 to 64 is like always like women more likely to be a sandwich caregiver. And for spousal care, for this type of sandwich, spousal care plus grandchild care is actually not significant differences. And adding them together is also very similar to this parent care patterns, like gender differences decrease and reverse in later life. So here maybe, yeah, due to the time limitations, it's just a kind of a glimpse into like how I plan to do this. It's still like ongoing work, and I plan to, because when you look from a life course perspective, you have a higher requirements for the data. Like you want to, it's like, it's not a snapshot, but you need to follow someone like at different time points. And so this is the HR simple design. So actually like for each specific cohort, for I find share this age range and have a balanced panels of different observations for different cohort at different age. And what I can obtain is something similar to this, like at different age. This is for early baby boomers and from age 55 to 61, and what is the distribution of their different types of care status. And yeah, I'll be happy. It's still ongoing work, and I will be happy to discuss this in the Q&A. And so I will jump to kind of a summary, like is that overall the share of caring for more than one generation simultaneously is very low, and men are more likely to be potentially sandwiched, whereas women are consistently more likely to actually provide care to multiple generations. And the gender differences is after age 65 just to reverse and decrease. And despite the descriptive nature of this project, I think it points out the importance of first distinguishing the potential and actual care. And jointly considering different cares to multiple generations, especially spousal care, which is always ignored in the sandwich care research. And also the potential for future research to adopt a life course perspective to understand its sequential patterns. So yeah, maybe I will save this for the Q&A session. And yeah, that's it. Thank you.
Thank you, Yongxin. So our last presentation is by Dr. Joseph Gaugler. Dr. Gaugler is a professor and chair in long-term care and aging at the University of Minnesota School of Public Health. He is also the director of Center for Healthy Aging and Innovation and both Center of Excellence on Dementia Caregiving. His research examines the effectiveness of long-term care for persons with Alzheimer's disease and other chronic conditions. So today, he is presenting his work on caregiving as a social determinant of health. Joe is joining us on Zoom today. So hello, Joe.
Hello, hopefully you can hear me okay.
Okay, so I think I'm turning it over to you.
Wonderful, thank you. Thank you for that kind introduction. Thank you for the invitation to join you here today. My apologies for not being able to be there in person. It wasn't possible for me to do so, unfortunately. And thank you too for those excellent prior presentations. I'll try to refer to them as relevant throughout my talk. And generally, it's not a good idea to start a presentation with an apology, but I think I'll do that in that I realize the title of today's conference, this excellent conference today and tomorrow, is really focusing on data-intensive approaches, and within this session on family caregiving. But I wanted to approach this presentation a little differently, really reflecting thinking that I've been doing. In my role, for example, as the director of what's called the BOLD Public Health Center of Excellence on Dementia Caring, but also some additional work that I've been involved with over the years, which is trying to frame caregiving more effectively. For those of you that aren't aware, the scientific literature on family care, particularly for older people, extends back at least 4 decades, if not more. There's been a wealth of not only descriptive research documenting the health implications of providing care to an older person, particularly older persons with various health conditions such as dementia, but now even the development of various types of strategies to alleviate some of the adverse health outcomes associated with caregiving. For example, ranging from psychosocial approaches to models of care to respite to just a whole range of intervention approaches. And so this subfield has really emerged into a number of different vibrant sub areas, but all kind of revolving around this key concept of caring for older people with health needs. Now, the way I've been seeing my work evolve over time, like many of you, starting the earlier parts of my career, really focusing on various types of descriptive studies, in my case, specifically in the dementia care context, and transitions that occur in dementia care over time, to the development of interventions, to now focusing on dissemination and implementation. I've been thinking more about, why is this work really important? Is it truly a public health priority? Is it a policy priority? And if so, why? How can we better position this work, including, for example, the 2 excellent presentations that have already occurred, as well as a lot of the other work that we may be involved in, into messaging around why this is a public health issue, why is it important, and how do we address it from that perspective. And what I chose to do today was thinking about caregiving within this emerging popular framework of social determinants of health. For those of you, and I'm sure many of you are familiar, what are social determinants of health? These are the conditions where we are born, grow up, and live, and how they influence our health outcomes over time. And perhaps as importantly, the various systems and structures that affect where we are born, grow up, and live. And again, how these things interact in complex ways to influence health. Does caregiving fit in this framework? And if so, how can we leverage that to further refine our work? So that's really what how I'm trying to approach this here today. So what is public health in general? Again, we talk a lot about public health, but what is public health, and specifically, why is caregiving a potential public health issue of concern? You see here some of the key hallmarks of what public health really is. It's concerned with improving the health groups of people equitably, with a major focus on eliminating health disparities, which are preventable systematic differences in health between groups of people based on various sociodemographic characteristics. And as I go through this list, think about how caregiving applies. Public health efforts are typically based on a socio-ecological framework. I'm not going to really go into that in depth here. I would imagine many of you are familiar, but really thinking of caregiving in context, where it extends beyond the individual caregiver into a family/community context, to a even broader context above and beyond that, including socioeconomic and structural considerations. Public health complements healthcare received in settings like hospitals and rehabilitation facilities. You see examples of how public health operates in other types of health areas. This issue right here, this area of public health concern, is where I think caregiving operates as an essential feature. When we think of optimal chronic disease care or optimal care to older people with various health conditions, oftentimes with co-occurring health conditions, core to those optimal models of care is the incorporation and integration of an unpaid individual, often a relative, a family caregiver, within the delivery of care, the planning of care, decision-making, and then also the overall management of the health conditions of persons, of an older person with some type of health condition. Finally, any condition, exposure, event, or experience that negatively impacts health or quality of life at a population level. Again, does caregiving fit any or one or more of these various domains? That's what I've been thinking about a lot. I encourage you to think about it too. And I would imagine, I would argue, for multiple of these, caregiving indeed is something that is of public health importance, as we're going to get to a little bit more here in detail. This is a socio-ecological framework. Again, you see the various levels and how they interact, interlock, and how they influence each other. Caregiving is no exception in terms of operating across these various levels of influence. However, when we look at the literature and we look at the methods we often use to adopt and study caregiving, I would argue we have not done a very good job across disciplines, even though there's a vast amount of research out there in caregiving, in really considering how society, social policies, certainly race, ethnicity, other key structural factors actually influence caregiving in terms of not only outcomes, but how caregiving is delivered, how long it's delivered, how community and other types of issues not only influence caregiving, but it also might be potential levels or targets of intervention, public health or otherwise. Again, many interventions that are developed and targeted to family caregivers often just focus on the caregiver herself, himself, themselves, not necessarily from an organizational community, certainly not even a social perspective. So there are many areas of work where we can consider. And again, one thing I was very excited about in hearing and listening to the prior two presentations was, in fact, there is some acknowledgement, certainly from a multi-generational perspective, of caregiving occurring really in a more complex way than just, for example, one person providing care to another in a unilateral way. So one area that I focus on a lot, and you'll notice the title of this slide, but I think you could even eliminate the term dementia here. But certainly when you look at caregiving, and if you take a survey of the existing scientific literature that's out there to date, we know that caring for older people with some type of need, functional or health, often is associated with a number of negative health effects when compared, for example, to age-matched non-caregivers. These differences in adverse health outcomes are magnified when you look at specific types of health conditions, particularly complex, chronic, insidious conditions. And dementia in particular has been the focus of much work. And when one looks and compares dementia caregivers to matched caregivers, for example, of other health conditions, or certainly non-caregivers, those differences in emotional distress, financial strain, work disruption, depression, anxiety, subjective health, the list goes on, is magnified. So again, thinking of that slide a couple slides ago, why is caregiving a public health priority? Here are some of the reasons that Aaron Bolden argued in a book that I had edited, and I certainly would argue as well. Number one, it affects the health of the population, not only caregivers, but care recipients as well. We know, for example, older adults with health needs that don't have a caregiver are at risk for negative outcomes. But alternatively, and this is the complexity and paradox of caregiving, those individuals who are providing that care, particularly for prolonged periods of time, are at risk for a range of potentially adverse health outcomes as well. So it certainly affects the health of the population, as you'll see shortly. When we consider the scale of care for older people, particularly unpaid care, it's significant. The effects may be unequally borne by some members of that population. You heard earlier, and we know women in particular are much more likely to be caregivers. Roughly 2/3 or so of all caregivers of older people with health needs are women. But also, if one goes and looks even more across other socioeconomic characteristics, for example, race, ethnicity, when one looks at African-American caregivers, for example, African-American caregivers are much more likely to provide more help to older people in need. Interestingly, they're less likely to indicate emotional disruption, and that may be in part due to the measures we use. They're not probably effectively culturally adapted for that context. But then African-American carers are more likely to indicate financial strain. So there certainly is some key intersectionality when considering caregiving and how it may be unequally borne by members of the population. And are there effective prevention strategies, or quite frankly, intervention strategies in general that could be employed to reduce these negative impacts? Yes, there are. The key issue, again, when we think of this from a public health standpoint and a social determinants of health framework, is how do we effectively disseminate and implement those interventions vis-a-vis policies or other mechanisms to ensure that the people who could benefit from them receive them? That is a key issue. It is a key gap when one is considering caregiving of older people in general. So what can public health do? Again, stepping back from our roles as researchers and looking at secondary data sets and understanding and describing caregiving is more taking a step back and maybe from a more global perspective, what can we do to actually alleviate the distress that is often associated with caregiving? Certainly from a surveillance standpoint, we must do a much better job of tracking who are caregivers at fairly, I would say, granular levels to better understand how is caregiving affecting our communities at a county level, at a state level, and how is that occurring over time. There certainly are national data sources that have been leveraged to study caregiving. You saw a couple of them already in the earlier presentations, but we don't know and don't have a good approach to estimating the prevalence of caregiving at, say, for example, a county level. One of my grand goals I would love to be able to develop is almost a caregiving prevalence map or a dementia caregiving prevalence map. You've seen this for other health conditions where they've been developed, where we can kind of see and map onto other, say, key health indicators of a given county or given catchment area, the prevalence of caregiving. The prevalence of caregiving in relation to the availability of community-based long-term services supports, hospitals, nursing homes, et cetera. Understanding that from almost a spatial analysis perspective would be very exciting, but I'm not sure we necessarily have good enough data sources to get to that point. Actually, in working with some colleagues, we probably do. It's just no one has gotten to that point of actually doing that. Education about caregiving and health risks they may be facing, using public health tools like health-related awareness and education campaigns. And you see a number of other public health strategies here that could be implemented to really help address what is a public health concern, which is caring for older people. That last point there is one I'm very interested in, which is, again, really thinking about what are the evidence-based interventions that exist. Again, there's a suite of them that are out there that do work to some extent. And more importantly, how can we now apply implementation science or dissemination research methodologies to get them out in the communities? Okay. This is a nice picture of the social determinants of health, and why I like looking at this is it is where does caregiving fit? If we believe it's a social determinant of health, and I would argue it is, it probably fits, for example, within the social and community context, larger domain. It certainly is influenced by all of these domains one way or another, but you could make a strong, compelling case that in fact, it probably sits as its own social determinant of health, however, a complex one. If you are a caregiver, that potentially puts you at risk for a number of potentially negative health effects. Alternatively, having a caregiver, if you're an older person, is potentially protective amongst various types of negative health transitions, for example, nursing home admission. So thinking of caregiving within this context of social determinants of health, I think is really important. This is a nice infographic. This is really based on some of the data collected by the CDC through their BRFIS survey. I'm not going to go through this, but it gives you a sense of the scope of caregiving and how prevalent it actually is and what caregivers are actually doing. More and more caregivers are assuming medically complex tasks that in the past have been the purview of hospitals or other healthcare settings, potentially adding to their burden and again, potentially highlighting the value of caregivers to our overall long-term care system. You know, depending on the survey you look at, roughly there's around 50 million caregivers or so of adults in the US, particularly if one looks at the NAC ARP data. Estimates vary depending on the methodology used, but nonetheless, if one places an economic value on caregiving in the US, it becomes evident very clearly, particularly even for specific health conditions like dementia, of this notion that really unpaid caregivers, particularly family carers, really are the core of the long-term care system in the US. So I'm going to conclude quickly here with, again, one final thought to leave you with, which is, given our heavy reliance on unpaid caregivers, can we expect to continue to rely on that source of long-term care? I edited 2 books, one in 2015 and more recently in 2021, that really address this issue of the family care gap. If one looks in the upcoming decades, and I apologize if you can't read this very well, it is estimated. Now, again, this is a good area of research, particularly for an entity like the MPC to tackle, I would argue, which is the future supply of informal caregivers. There is certainly debate in the scientific community about whether this graph truly represents availability of caregiving, but nonetheless, if one takes this graph at face value, which was developed by the ARP, we can expect a fairly significant drop off of available family caregivers for older people with health needs in the upcoming decades. Given our heavy reliance on family caregivers, how are we going to offset that gap? What does that gap mean? So again, thinking of this from a social determinants of health framework, from a public health framework, I think is really important. And particularly this idea of, we can study caregiving till we're blue in the face, but if we're not going to have as many of them in the upcoming decades, what does that really mean for long-term care for older people in the US and perhaps other countries as well? Okay. I'm probably going to skip through this for the purposes of time. I know we want some time for Q&A, but in my subsequent slides here are reasons for the family care gap that have been documented. Again, excellent researchers like Brenda Spillman have been looking at driving down a little bit more into the science of what do we really need to have methodologically to understand and estimate what is the future family caregiving gap. But nonetheless, there are a number of socioeconomic trends that seem to be pointing to a lower availability of family caregivers. And in my book, again, hopefully, if you're interested by it, hopefully someone will, is how do we actually bridge this family care gap? And in the Bridging the Family Care Gap book I edited, the final chapter, I actually propose really 4 key areas where how we can address and offset the family caregiving gap. And, you know, we talk about developing a national family caregiving strategy. For those of you that are interested, there are states that have been tackling how to address ways to better support family caregivers. A state in particular is the state of Washington and their Trust Act, which is going to greatly expand access and affordability of community-based long-term services and supports. From a policy standpoint, and I'm sure the scholarly community would be very interested in evaluating state-level policies like that, because quite frankly, when we look at caregiving and what's being done to help address caregiving, much of the action is at the states, not nationally. So I'm going to just move ahead here and conclude so we have time for Q&A. But again, thank you for the opportunity. Hopefully this wasn't too jarring in terms of a more broader perspective. But again, I think it's really important for us to couch this work, this descriptive work, in a larger context of caregiving as a public health priority. Thank you.